Good evening, everyone. Thank you very much for taking some time out to join us on what is our fourth webinar of Bone Cancer Awareness Week 2020, focusing on radiologists. In a moment, I'm going to hand over to my colleague Zoe, who's just going to introduce the session. But I'm Matt, I'm the Head of Fundraising and Communications, and just to let you know a bit about the format. So everybody is on mute, just so that we don't have background noise. Your video is set to off. You can turn it on if you like, but just please bear in mind the session is being recorded so that we can play it later and upload it to YouTube. If you have any questions throughout the webinar, we will try and endeavour to answer a couple at the end, but there may not be time. If we don't have time, we have got a recording of all the questions that are asked in the comments, and we'll make sure we get back to you with responses to those questions. But if you do think of something as we progress, please do pop it into the comments bar. One of us will keep an eye on it, and at the end we'll put it to our speakers for you. That's pretty much it, I think, for now. I'll hand over to Zoe. Just one note to our speakers. Jonathan, I'm just going to unmute you. So Jonathan and Rajesh, please don't put mute on, because if you do, you'll not be able to unmute yourself. Okay, so Zoe, over to you.
Hi everyone, I'm Zoe. I'm Head of Research, Information and Support at the Bone Cancer Research Trust. So I'm just going to give you a bit of an overview before I hand over to the experts. So I am just going to share my screen. Can you see that? Yeah. Okay, so I thought it might be a good idea to give you a bit of an introduction to Bone Cancer Research Trust. Some of you might not have heard of our charity. So in 2004, a group of families who had lost children and young adults to primary bone cancer came together. They had all been fundraising individually, and they were brought together by an oncologist called Ian Lewis. He recognised the fact that they were all trying to do things independently and felt that they could achieve more with a bigger impact if they came together. So in 2006, that's what they did, and they registered the Bone Cancer Research Trust. Today, we are the leading charity dedicated to primary bone cancers, and we offer hope to those affected by the disease. Our vision is a world where primary bone cancer is cured for all patients, and our mission is to save lives and improve outcomes for those patients through our 4 pillars of research, information, support and awareness. We're a very small team compared to a lot of charities. There's 16 of us at the minute, and we are based in the sunny north in Leeds. So I just wanted to tell you a little bit about why we want to do this and why we want to raise awareness. And it goes back to our patients. So this little girl on the screen is called Harmony. Harmony presented with a lump in her arm and pain that you can see here. She initially went to a minor injuries unit and was prescribed antibiotics for an infection. She went to A&E, and she also then went to a consultant, a paediatric consultant. And even though there was no markers for infection in her blood, they sent her home again with antibiotics. It was only when a family friend recognised this lump, he was a paramedic, and he booked them an urgent x-ray. And that's when they saw that it was something far more sinister. The x-ray showed that there was bone destruction, and Harmony was diagnosed with Ewing sarcoma. And then this is Claire. So Claire had pain. She went to a GP. Her GP referred her for physiotherapy, and it was a physiotherapist that picked up that something really wasn't right. The physiotherapist wrote back to the GP, and the GP then referred on for urgent imaging, and Claire was diagnosed with Ewing sarcoma. Claire's doing really well now. She is well and healthy, and she has just started a little family. Our charity is patient focused, and we have a lot of patients that have shared their story with us. And I would really encourage you to visit our website and look through some of these stories. They're all unique and they're all really, really worth a read. So why do we want to increase awareness amongst healthcare professionals? In 2015, we carried out our first piece of stakeholder research, and on the back of this, we developed a report called Living with and Beyond Primary Bone Cancer. And it was really this piece of work that allowed us to identify and gave us the evidence in the first place that our patients really did have a really troubled time with their diagnosis. And it's this quote that really stood out to me. When I was finally diagnosed, I didn't know if I could go through the treatment. We had fought for so long, I didn't know if I had any fight left in me. And this was a quote from a 14-year-old patient who was diagnosed with osteosarcoma. And that's what we want to change. So last year, in 2019, we hosted 5 medical students from the University of Sheffield, and we asked them to review our healthcare education materials. And they chose to focus on raising awareness amongst medical students. And they developed these flashcards that you can see here. This is the front and this is the back. And they are kind of postcard size. They're matte, so they allow students to write on them. And they cover everything from risk factors to presentation to management, all the way through to epidemiology. And although they were developed with medical students in mind, actually they've been taken up by GP practices to do reflective learning, and they've been used by physiotherapists. And it was really this that kickstarted our new kind of awareness project. So we launched in July a collaborative project with Children with Cancer, the Bone Cancer Awareness Initiative, and this was launched in July 2020. It's a 100-day long project, and it's culminating in this week, which is Bone Cancer Awareness Week. We kicked this off really with a patient survey. We wanted to know how bad the problem was with patients, and the best way to understand that is to get it from the patients themselves. It had 2 main areas of focus. So there was a focus on the breadth of presenting symptoms, so that we understand symptoms irrespective of where the tumour is anatomically, and the time and route to diagnosis, to understand where patients present, where they're referred onwards. So we had 739 responses, 312 of these were from in the UK and 426 from outside the UK. One didn't give us their geographical location. So I'll just talk you through some of the key findings. So this is the age at diagnosis. So you can see it has quite a normal incidence profile for primary bone cancers. There's a peak at children and young adults, and there's still cases in later life. The patients that answered the survey were all diagnosed fairly recently, or the majority of them were. And when we look at where they reported their symptoms initially, overwhelmingly they went to their GPs, a few to A&E, and then very few to anywhere else. When we look at the average number of times they visited a healthcare professional, it's actually 8 in the UK, which is an awful lot of visits. And 58% of those responding visited 3 or more different healthcare professionals before they had a diagnosis. Over 25% of patients responding waited more than 7 months for a diagnosis, and 13% more than 12 months, which is a very long time. So in terms of the survey responses that are pertinent to you as radiologists and radiographers, we found in our survey that 32% of patients experienced referred pain, which might be quite significant depending on how an X-ray is requested. And in the survey, 44% of patients needed more than 1 X-ray for anything to be detected. So on that note, I'm going to hand over to the experts. So I'll stop sharing my screen and I'll hand over to Rajesh.
Thanks a lot to Bone Cancer Trust as well as Zoe for inviting me to take part in this bone cancer awareness program. So today what we are going to do is, as Zoe has stressed, most of the tumors are mainly diagnosed on the initial radiograph. So today what I'm going to do is go through some of the salient features that one needs to look at and see how to analyze those radiographs to come to a sensible diagnosis and hopefully pick up the tumor at the earliest. Just to give you a spectrum of cases that you can see in patients with tumors. So I'm going to show you 5 cases. So this is a 20-year-old who presented with ankle pain following a football injury. And these are the radiographs. I give a few seconds for you to see and analyze. Another second case is a 16-year-old. Again, he was playing football and he had a football injury. So he went to A&E with pain and swelling. And these are his radiographs. What we're going to do is at the end, we are going to go through these radiographs at the end, and I'm going to give you the answers for the questions. Another 22-year-old, similar history of trauma, and then presented with this lesion involving the proximal tibia. This is a relatively elderly, he's 60-year-old with left hip pain, and these are the radiographs. And the last case today is a 28-year-old fit and well person who does gym and all, and he presented with left hip pain. So this is just a spectrum of cases that you can come across in your routine practice. Before we go on to that, I want to let you know about MSK Radiology for You, which is a free website and app, and it's got more than 4,000 cases of various pathologies of musculoskeletal imaging. In particular, we have over 350 osteosarcomas, Ewings. You can see a spectrum of all these tumors, and it's all free, and you can download it as an app as well. So without further delay, so if you look at tumors itself, if you go back to the top 10 causes of death in 1949, cancer was number 10. Moving on almost 50 years, cancer is increased in incidence, and it is the 3rd commonest cause of death. What about primary tumors? On an average, we see about 500 new bone tumors in the UK. If you look at the incidence, osteosarcoma is about 3 per million per year, and Ewings is about 1.5 per million per year. So what is the role of imaging? Imaging is the key because it helps us to analyze the lesion. It helps us to stage. In order to perform biopsy, also we use imaging, either CT or ultrasound. If somebody has had chemotherapy, in order to assess the response, imaging is key. And obviously, if somebody has had treatment to look for local recurrence, metastasis, imaging is the key. But for today's talk, I'm just going to talk about lesion characterization on radiographs predominantly, and I'm also just going to cover a bit about surgical staging. Obviously, in radiology, we have a spectrum of modalities. We have radiographs, CT, MRI, bone scan, ultrasound. And in fact, I haven't even talked about PET CT, PET MR. So what I'm trying to say is that there is a spectrum of modalities that can be used in patients with suspected bone tumors. But the key is that radiographs are the main key. So obviously, all these modalities are not required in every patient. But for bone tumors, we always advise the referrer or the referring hospital to do a radiographs. It's not very uncommon for us to see CT, MR, bone scan, PET scan, but no radiographs. Always do radiographs if you suspect bone tumors. It's always important to identify the tumor mimics. If somebody has infection, stress injury, or normal variant, if you're not aware of all of these, then you can misdiagnose these as tumors. So it's important to identify these. And in fact, in a study way back in 2001, 50% of the cases referred with infection were confused with tumors. So always tumors and infection are good mimics. Just to give you a spectrum, obviously, not every tumor follows one particular rule. For example, all these are all different variants of osteosarcoma. So you can see that the appearances can be different, just like a chameleon. Whenever you look at a radiographs or you suspect a patient with tumors, there are certain features that you need to know. First of all is age, site, is there any pre-existing condition, and obviously as a radiologist, the radiographic appearance. So let's look at some features. The first is the age. Age is the key. So this is a standard table that is there in most of the books. And if you see, as Zoe has already said, most of the bone tumors happen in the first and second decade. So just by using a cutoff of about 20 years, the other tumors of hemangioma, of metastasis, chordomas, myelomas can be excluded. So just by using an age criteria, you can narrow your differential diagnosis. For example, here we have a 6-year-old on the left of the pelvis and a 66-year-old on the right with elbow pain. You can see multiple lucent lesions, multiple dark lesions within the bones. Both look similar, but just because of the age, the lesion on the left is LCH and the one on the right is myeloma. What about the site? If you go to Rome, if you see a picture of Colosseum, you know that you're in Rome. Or if you see the Taj Mahal, you know that you're in Agra in India. So similarly, whenever you look at the tumor in the bone, you can either see in longitudinal plane or an axial plane. So when you look at a longitudinal plane, whether it's in relation to the growth plate, which is the epiphyseal, whether it is all the way to the joint, which is subarticular, metaphyseal, diaphyseal. I'll go through all of these. And when you cut the bone in the axial plane, whether it is within the medullary cavity, within the cortex, just outside the cortex, what we call is periosteal or parosteal. And based upon this, you can come to a sensible diagnosis. So here, what I'm showing you is, so this is the epiphysis, this is the metaphysis, and this is the diaphysis. So these are the different types of bone lesions that you can see. Some of them are benign, some of them are malignant. But just by looking at the age and the location, you can come. For example, if you have a lesion involving the physis in a patient who is 10-year-old, you can say that your diagnosis is a chondroblastoma. If the lesion is involving the diaphysis and the patient is around 10-year-old, chances are it is Ewing sarcoma. So this is a simplified table which shows that if it is in the epiphysis, your differential diagnosis is between giant cell tumor chondroblastoma. If it is in the metaphysis, it's mainly osteosarcoma. And if it is diaphysis, it's Ewing's. So location is the key. Just to give you an example, here you can see that the lesion is involving the physis of the distal femur. So this is a case of chondroblastoma. And in this case, because the physis has not fused and the patient is around 16, so this is chondroblastoma. Unlike this one, it is again in the physis going all the way to the joint, but this patient is 25. So this is a case of giant cell tumor. Giant cell tumors are common after skeletal maturity. What about this one? You can see that the physis is clear, but you can see this dense opacity, osteoid matrix involving the metadiaphysis. So this is osteosarcoma. If it involves the diaphysis of the tibia, then obviously your differentials are adamantinoma. So just by location, whether it is epiphysis, metaphysis, and diaphysis, you can come to a diagnosis. Now let's look at if you cut the bone in an axial plane. If the lesion is within the bone, for example, in this case, the lesion is within the bone, what we call is intramedullary. This is a solitary bone cyst. If there is expansion of the bone, we call it as an aneurysmal bone cyst. These are very common, these lesions where it is cortical based. Another one here, these are non-ossifying fibromas. These are benign bone tumors. And most of the times they can be incidental. The reason why this patient presented was because he has got a fracture through the non-ossifying fibroma. So this is not a malignant lesion. What about this one? Here you can see that the medullary cavity of the humerus is normal, and the same here in the femur, it's normal, but you can see this periosteal reaction involving the periosteum, in this case, a periosteal chondroma, or in this case, you can see aggressive periosteal reaction. This is a case of periosteal osteosarcoma. A similar one, in this case again, it's involving the parosteal, and it's more dense when compared to the one that I showed you before. And this patient is 35. And if you see any lesion which is so dense behind the knee, posterior to the femur, your diagnosis is parosteal osteosarcoma. What about pre-existing conditions? Yes. If somebody has any pre-existing conditions, for example, in this case, you need to know the ethnicity. For example, as I said, infection can mimic tumors. So if you have a person from Asia, for example, in this case, presenting with this destructive lesion involving the distal radius, or in this case, the fourth metacarpal, think about infection. And obviously, because of in Asia, TB is very common, and tuberculosis can mimic tumors. If somebody has underlying sickle cell, again, osteomyelitis is common in these patients, so ethnicity is important. I talked about pre-existing conditions. There are certain pre-existing conditions, for example, Paget's. You can get Paget sarcoma. Patients with osteochondroma, you can have chondrosarcomatous transformation. So if somebody has a thick cartilage cap of an osteochondroma of more than 2 centimeters, then you have to think about chondrosarcomatous transformation. You can have multiple enchondromas, what we call as Olliers. Fibrous dysplasia, tumors within fibrous dysplasia is very rare, but it is possible. If somebody has had radiation for some pre-existing condition, then they can develop tumors, what we call as radiation-induced sarcoma. And very rarely you can get tumors when infections in patients with chronic osteomyelitis. So just to give you an example, so this is a 20-year-old, it's an 18-year-old, and you can see on the right, this is the normal hip, whereas on the left, the ilium, the hemipelvis is quite hypoplastic. And the reason is this patient had neuroblastoma as a kid. He has had radiotherapy. He was treated and he was all clear. But now when you can see the permeative destructive lesion involving the left superior pubic rami, on an average, normally they take about 5 to 10 years to develop after radiotherapy. So this is radiation-induced sarcoma. Obviously, as radiologists, the key feature that we are after is the radiographic appearance. So whenever you look at any tumor, there are certain things that you need to see. You need to look at the margin of the tumors, and then I'm going to go into detail about that. You need to look at the cortex. What does the cortex do? Is there any soft tissue component in addition to the bone? How is the matrix? And obviously, what is the periosteum doing? Is there a periosteal reaction? And we'll look into each of these in detail. Because the rate of the lesion can show us what the likely tissue of origin is. So we have 3 types of margins. First margin is called geographic margin. What I mean by geographic margin is you can take a pencil and you can draw around the lesion. For example, in this case, on the left, you can see a solitary bone cyst involving the femoral neck, an aneurysmal bone cyst involving the ulna or the olecranon. And I showed you the case of non-ossifying fibroma. In all these cases, you can say where the demarcation is between the normal and abnormal bone. What about this one? In this case, this is a case of Ewing's, osteomyelitis, and LCH. You cannot exactly say where the abnormality starts and where the normal bone is. We have two patterns. One is the classic moth-eaten pattern where you have small foci of lucency. So this is a magnified view. Again, what you basically see is destruction of the bone, or you can have this permeative appearance where the tumor goes through the trabeculae into the medullary cavity. In all this, you cannot exactly say where the tumor starts and where the tumor ends. So this is another case of Ewing sarcoma. This is a magnified view, and you can see all this destruction, the lucencies. This is all tumor infiltrating into the bone. Obviously, the body will try to repair if there is an abnormality. What we mean is there will be a cortical response. Based upon the type of cortical response, you can assess the growth of the lesion. If the growth of the lesion is slow, then the cortex can expand and control the lesion. However, if the tumor grows at a rapid pace, then the cortex cannot control the tumor and it will destroy the cortex. For example, in this case, you can see an expansile lesion involving the metaphysis of the proximal fibula. So this is a case of aneurysmal bone cyst, and this is a classic ground glass appearance of fibrous dysplasia. So what about this one? This is very common in hands and feet. What we see is a lesion involving the proximal phalanx, and the cortex is thinned out, but it's still holding it. And we will come to the matrix. So this is what we call as enchondromas. These are cartilage tumors, and they're very common in the fingers and toes. But, so this scalloping of the cortex is what we call as endosteal scalloping. This is what I was talking about. If the tumor goes at a rapid pace and the bone cannot control it, then it destroys the cortex. For example, in this case of osteosarcoma, you can see that the cortex is all destroyed. And similarly, in this case of giant cell tumor involving the lateral tibial condyle, the cortex is destroyed. So whenever the cortex is destroyed, it means rapid growth. We are not happy. It's worrying. But it's not always true. For example, in this case, this is a case of osteosarcoma. And if you see what I said before, if the cortex is intact, it means slow growth. But in this case, though the cortex is involved, there is large soft tissue component. So it's not valid in this patient. And the same with Ewing's. And when you do MRI, in this case, you can see the tumor involving almost the entire upper half of the femur with a bit of a soft tissue component as well. Another patient, radiographs, pretty normal, a bit of sclerosis maybe, but look at the MRI. You can see that the bone itself is normal, but the tibia is normal, but there's a massive soft tissue extraosseous component around the fibula. So sometimes intact cortex does not necessarily mean it's a slow growing tumor, but it just gives you an indication. Another patient, again, cortex is intact, whereas in this case, though the cortex is intact, there is what we call a scalloping or saucerization. This is very classic of Ewing's tumor, Ewing's sarcoma. And you can see this large soft tissue tumor, which is scalloping the medial part of the femoral shaft. Again, in this case, rapid growth. The next feature that we are interested in is soft tissue component or extraosseous component. In this case, osteosarcoma, large destructive lesion with a large soft tissue component. Ewing's, as I said, it's very common in Ewing's that the radiographs will underestimate the extent of tumor. So if you look at Ewing's in this case, the bone destruction is not a lot, but there is a soft tissue component. The next feature, whenever you look at a tumor, is to see what is inside it. Is it as dense as this? Just like bone. If you have a tumor which is as dense as this, it's osteoid. So osteosarcoma, osteomas. So these are all, you can see that increased density of the lesion. So these are all different types of osteoid matrix in different types of osteosarcoma. When you compare that with this, in this case, what we see is tumor involving the femur, the proximal phalanx, and the metacarpals. And you can see rings and arcs. This implies that the tumor is arising from the cartilage. So we are thinking in terms of chondrosarcomas and enchondromas. Or sometimes the matrix can be just like a whale. For example, in this case, classic ground glass appearance. Whenever we see ground glass appearance on radiographs, we know that this is fibrous dysplasia. The other feature that we need to assess whenever you look at radiographs is the periosteal reaction. Depending upon the type of periosteal reaction, it can be solid and continuous like this, which implies slow growth as in case of an osteoid osteoma. You can also see a lamellated periosteal reaction. What I mean is single layer of periosteal elevation and new bone formation, classic location, posterior part of the proximal tibia, stress fracture. This is not tumor. What about this one? You can see that there's a permeative lesion. We can't clearly say where the normal bone is, where the abnormal bone is. There is different types of periosteal reaction. And if you mag it up, you can see there are multiple layers, what we call as onion skin appearance. This is not good. That implies it's an aggressive lesion. This was the case of an osteosarcoma. You can see a classic onion skin appearance of lamellated periosteal reaction, as in this case in Ewing's as well. Sometimes the tumor will go at a rapid rate and the new bone formation will be almost perpendicular to the shaft, as in this case, what we call a spiculated periosteal reaction. Whenever you see this, you have to think about periosteal osteosarcomas, and you can also very rarely see it in Ewing's sarcoma. The periosteal reactions can be continuous or can be interrupted. The classic teaching is of a Codman's triangle, where there is interrupted periosteal reaction, or the classic lamellated onion peel appearance, which is continuous of Ewing sarcoma. So, or in some cases, you can have a mixture of them. So, just to give you an example, this is a periosteal chondroma, a Codman's triangle. You can see that the periosteum is elevated, new bone formation, what we call the Codman's triangle of osteosarcoma. And in some cases, it can be very subtle. For example, in this case, you can just see this subtle periosteal elevation and new bone formation. Again, a case of osteosarcoma. Sometimes you will have a mixture of all of these. You can have Codman's triangle, spiculated periosteal reaction, lamellated. So you can have a mixture as well. So that is as far as radiographs are concerned. What about CT? CT is useful in order to identify the matrix. If you're not sure what the matrix is, then you can use CT. CT can also help us to assess the cortical thickening. Is there a small lucency? For example, in this case, you can see a small lucency within the thickened cortex. So this is a case of an osteoid osteoma. It is not a malignant lesion. And it's very easy when you diagnose this, because what you do is you put a needle into the center of the lesion and burn it. And that itself will treat the tumor. The other important role for CT is to identify metastasis. Patient with osteosarcoma, Ewing's can have metastasis in the lungs, and in order to diagnose them, you have to use staging CT. The key modality after radiographs that we use is MRI, and MRI is very good for local staging. As in this case, you can see a massive tumor involving the humerus with a large soft tissue component, and you can see that it's already gone into the joint. And that is very useful for Jonathan to know, because accordingly the management will change. It will also help us to assess what is inside the tumor, what is inside the lesion, for lesion characterization. What we do is, whenever you see a patient with tumor, we image the whole bone, including the joint above and joint below, and we tend to use standard T1 and STIR and T1 and T2 fat set. It's important to image the whole bone, because I'll show you examples where the tumor can skip what we call a skip metastasis. We don't use contrast. I know several centers use contrast. We tend not to use contrast. And the reason is because contrast does not add enough information, any extra information in bone tumors, in addition to what we can get. And you need to be aware of the latest papers, which shows that the gadolinium that is used for contrast can be deposited in the brain, and nobody knows what the long-term effects of that is. So hence, we tend not to use contrast in our center. So just to give you an example, here we have got tumor involving the proximal tibia, and another one here involving the distal femur. But whenever you have tumor, a bone tumor, you have to image the whole femur. You can see that there's a skip metastasis here. And that is important for Jonathan to know, because instead of doing a resection here, he has to do a higher resection to take the entire tumor off. So hence you have to image the whole bone. And the same on bone scan, you can see the main tumor is involving the distal femur, and you can see multiple black spots, which are multiple tumors which have just skipped and extended along the entire shaft of the femur. The other thing is MRI also helps us to assess what the lesion does. For example, in this case, is there any edema in relation to the lesion? Is there any fat? Is there any fluid levels? And I'll show you some examples. Whenever you have a lesion and you've got edema, and if the edema is 3 times the size of the lesion, if the edema is 3 times the size of the lesion, it is unlikely to be a malignant bone tumor. You have to think about osteoid osteoma, chondroblastoma, osteoblastomas, or infection and stress fractures. And it's important to know. Just to give an example of edema, in this case, you can see florid edema of the femoral head and neck with joint effusion. And the lesion is very tiny. It's just an osteoid osteoma. And you can see on CT, the lesion is so tiny, extent of edema is huge. The same again here, small lesion, huge amount of edema. These are all not aggressive or not malignant lesions. The other lesion which produces edema involving the physis is chondroblastoma. But these are all benign bone tumors. Nobody likes fat, but as radiologists, we like fat. And the reason is whenever you see fat within the lesion, it implies it's benign. If somebody has tumor, they have radiotherapy, chemotherapy, the tumor or the periphery of the tumor is replaced with fat. If somebody does surgery, we look for fatty infiltration. Whenever you look at fat, you can see it in intraosseous lipoma, hemangiomas, or bone infarcts. Just to give you an example, so you've got a lesion involving the femoral head, you do MRI, and you can see that there is fat within. This is a case of intraosseous lipoma, nothing to worry. Another patient with multiple lesions involving distal femur, proximal tibia, bone infarcts, nothing to worry. The other feature that you can see is fluid levels, and I'll show you some examples. So whenever you have a tumor, the tumor can undergo necrosis, and you can have separation of the blood and serum, and hence you will see these classic fluid levels. So whenever you see fluid levels, you have to think about aneurysmal bone cyst, giant cell tumors with secondary ABC, chondroblastoma, and don't forget telangiectatic osteosarcoma. So this is exactly what you see. You can see this layering case of aneurysmal bone cyst involving patella, giant cell tumor of the proximal tibia with multiple fluid levels. And this is the aggressive form of osteosarcoma, what we call as telangiectatic osteosarcoma. Bone scan, yes, bone scan is mainly used to see if there are multiple metastases, if there are any skip mets, or in patients with chronic recurrent multifocal osteomyelitis. So having gone through all of these, let's see. So this is a 14-year-old, and you can see the lesion is involving the epiphysis. So radiologically, we would have thought that this is a case of chondroblastoma because physeal lesion before skeletal maturity, chondroblastoma. Whereas this one is involving the proximal tibia, it's in the metaphysis, it's lucent. So you are either thinking in terms of aneurysmal bone cyst. Very rarely you can get osteosarcomas. Infection is also a possibility, but it's not always correct because in this case, you can see this is a telangiectatic osteosarcoma and this is chondroblastoma. So all that glitters is not gold. So whenever you see a suspected bone lesion, this is what we suggest. If you suspect a bone lesion, do a radiographs of the region of clinical concern. If you're not happy with it, if there are indeterminate or potentially malignant lesion, we advise doing an MRI involving the whole bone, joint above and joint below. If you're not happy with the CT, you can do a low focal. You might have to do a focal CT to look at the matrix. If the lesion is definitely benign, that's fine. If it is still indeterminate, patient would need a CT chest and then biopsy. So these are the references, and I'm just going to go through those cases that I showed you. The first one was a 20-year-old male with ankle pain, and we can see this classic fluid levels. So just based upon what I have said, you've got an expansile lesion involving the distal tibia, involving the metaphysis extending to the physis. So it's got fluid levels, but because it's extending to the subchondral bone, radiologically, this is giant cell tumor with secondary ABC. And this is an aggressive lesion, permeative pattern. You got periosteal reaction, soft tissue component, metaphysis, osteosarcoma. What about this one? Eccentric. This is eccentrically located lesion, lucent. It's a tumor going all the way to subchondral bone after skeletal maturity. Your diagnosis is giant cell tumor. So just by age, location, what it does, where it extends, you can come to a diagnosis. Unlike this one, 60-year-old, most of the bone tumors are in the first and second decade. After 35 years, you have to think about metastasis. So in this case, this is a metastatic lesion. And patient on questioning, patient has history of renal cell carcinoma. This one is a similar one, but look at the age. The age of the patient is young. So it's very unusual, but the location is classic. This is a case of clear cell chondrosarcoma. If you have a lesion involving the proximal femoral physis in a relatively young person, 20 to 30, 35, you have to think about clear cell chondrosarcoma. Thank you. I hope that was useful.
Thanks very much, Rajesh. Are you okay to stop sharing?
Yeah.
You just press escape.
Yeah.
There you go. Fabulous. And we'll hand over now to Jonathan.
Thanks. So I'll just share my screen. Is that working?
Yep.
Yeah, perfect. So I work very closely with Rajesh, and we do our MDTs every week together, and we do lots of daily MDTs in Birmingham. At the Royal Orthopaedic Hospital in Birmingham, we cover most of England and Wales for bone tumours, as you can see on the right, and we receive thousands of referrals for suspected bone and soft tissue sarcoma per annum. We discuss lots and lots of cases in the MDT, both bone and soft tissue sarcomas, and we have 8.5 consultants with 11 all-day operating theatres a week, with a large database of previous oncology referrals. And so I was asked to talk a little bit about how we manage our bone tumour cases, and then to give you some case examples of things to miss, particularly with a focus on awareness. So for the majority of our patients, we manage them with resection and endoprosthetic reconstruction. But for some of our patients, we try more novel surgical procedures, such as biological reconstructions, where we would try to replace the bone with donated bone or with autograft to try and give them a more long-standing reconstruction, particularly for the younger patients. Some patients, thankfully, can just have an excision alone, and sadly, some patients do end up having an amputation. In children, we have very expensive growing EPRs, which we can use a magnet to make them lengthen, as in this young girl who had a pathological fracture through an osteosarcoma and a growing distal femoral prosthesis. And it means that as they grow towards skeletal maturity, we can keep pace and avoid a limb length discrepancy. In the upper limb, sometimes we can transfer the growth plate from the proximal fibula. Sadly, they do tend to fracture, but they have a good chance of preserving growth, as in this young lad with an osteosarcoma, as they approach skeletal maturity. And then also in our adult patients, we might use donated bone, which are called allografts, which can be tend to be irradiated, having been cleansed. And we might combine that with a vascularized fibular autograft as well. And it's a particularly good option in the tibia, where metalwork under the skin tends not to be a good option. And as I said, endoprosthetic replacements can be done all over the body, can be done in children and in adults. They can be made bespoke or off the shelf. And the advantages of using endoprosthetic replacements is that we get patients moving very, very quickly. They're, with a distal femoral or a proximal femoral endoprosthesis, they're up and about walking the next day. They're very good for oligometastatic bone disease, for controlling disease. But there's lots of investigations. One of my particular interests is the modes of failure and how we prevent those happening in our patients, so that we can avoid revision surgery, which can be limb-threatening. So hopefully we offer our patients a good functional results. This is one of our patients carrying the torch prior to the Olympics. He's actually had a distal femoral endoprosthesis. And the other thing that we specialise in Birmingham is doing pelvic surgery for bone tumours, which can be quite rare, but is certainly very specialist. And we've migrated over the decades from using custom endoprostheses, which suffer high rates of infection, to doing a Harrington procedure for selected cases to reinforce the periacetabulum. Then we've moved on to trying a radiated autograft, where we would excise the pelvis and then take it and it has radiotherapy. And then we remove the tumour by curetting it and then plate it back into the pelvis. But again, sadly, that's complicated by infection. And nowadays we prefer to use an ice cream cone prosthesis, which is the upside down stem forced into the posterior ilium, because that has a good chance of an excellent functional recovery. We also nowadays like to use satellite navigation to remove the tumour. So we use the satellite navigation to help us do very complicated osteotomies during the procedure, and also to help us with our reconstruction, so we can put the ice cream cone into the posterior ilium in exactly the right place to prevent it failing and coming loose. And then when we come to reconstruct the hip and do a hip replacement, we can use it to recreate the normal inclination and anteversion of the native acetabulum. and hopefully we can offer our patients a good functional result that outlasts their lifespan. So these types of reconstructions have good oncological results, particularly with the navigation, and good surgical outcomes. Nowadays, we're using more and more computer-aided design and additive manufacturing, so 3D printing, using a dust substrate to form a very complicated trabecular type structure, which is stronger and lighter and replicate the trabecular bone and allow the native bone that's left in the pelvis to grow into the metal to hold it fast and stop it coming loose in the future. So my job is to save life and limb. And allied to the work that Bone Cancer Research Trust have been highlighting this week during the Bone Cancer Awareness Week, it's all about early diagnosis. We've learned about routes to presentation. We know that most patients go to their GP first. Some patients, particularly children and young adults, end up in A&E, sometimes more than once, and often get referred to fracture clinic. And all these patients are going to have x-rays which are going to be presented to radiologists. Nowadays, we're seeing more and more delays to diagnosis, particularly after the COVID crisis. So hopefully this talk and all of the efforts made this week by the charity will help to raise everyone's awareness of these rare tumours. So a few case series just to discuss similar cases that you might see. This is a young lad referred from the northeast. He had a history of hip pain for about a month. And then he stepped down a curb as he was about to cross the road to chase after a bus. And as he did so, his leg gave way and he fell to the floor. And he crawled to the curb and called an ambulance and was taken to A&E. And the X-ray report said intracapsular hip fracture as shown. And as per the National Hip Fracture Guidelines, he was taken to theatre very, very quickly and had pins put in his hip, but no further imaging or investigation. And after his cannulated hip screws were put in, he was referred for fragility fracture secondary prevention in a 33-year-old male. 6 months later, things were deteriorating. He'd had a bone scan. He'd been seen by a metabolic bone physician and an immunologist. And now he had an established non-union of his hip fracture and was referred for total hip arthroplasty. And it was at this stage, when they removed the screws, that they noticed the white stuff coming out of the bone. So they stopped and ceased the procedure, took samples from the bone, and the histology sadly showed a clear cell chondrosarcoma. So he had some staging imaging performed. Thankfully, his staging CT chest was clear, and his T1 weighted MRI showed an established fracture non-union, and you can see the tumour coming into the proximal femur down to the metadiaphysis, and the fluid sensitive sequences showing the previous incisions and scarring and the nice position of the screws in the femoral head, but did confirm intra-articular contamination. And sadly for this young lad, the only way that we could cure him surgically, because this is a disease that's refractory to chemo and radiotherapy, was for him to have a hindquarter amputation. So in this case, what was suspicious was his history of prodromal pain. Stepping down a curb is not an injury mechanism that's consistent with a hip fracture in a 33-year-old male. And so in this case, they should have stopped and scanned him and taken a sample from the hip to find out why his hip had fractured. So another case, a 55-year-old head teacher with a 6-month history of pain in his knee. He'd had x-rays of his knee performed by his GP, which were normal, showing some early degenerative change, but nothing particularly significant. His GP gave him injections into his knee with no improvement, so he had an x-ray of his hip, and then was referred for physiotherapy. Again, no improvement in his symptoms, and by this time he developed severe pain at night, not just with walking. He was unable to bear weight, and he presented to A&E with a fracture of his mid-shaft of his femur. He underwent the appropriate local and distal staging, so an MRI scan of the whole bone, as Rajesh said, and staging CT of his chest, which thankfully showed this was non-metastatic. And he underwent excision and endoprosthetic reconstruction, which meant that he was out of bed and up and about walking with crutches the next day. So what's interesting in this case was that he'd had x-rays of the joint above and below, but not of the whole femur. Perhaps his pain was referred to the knee initially and it wasn't felt to be in his thigh. but also the history of the pain, the fact that he had pain at night and the severity of pain was out of keeping for somebody with arthritis or degenerate of the knee or of the hip. Again, his fracture mechanism turning around in the kitchen is not normal for a 55-year-old pitching up with a mid-shaft femur fracture. So again, they should have stopped and thought, done a scan and taken a biopsy. This 72-year-old gentleman presented with shoulder pain to his GP, had pain at rest and not with movement, but he was known to have rotator cuff tendinopathy, previously had an ultrasound scan some years ago, which had shown some degeneration and tearing of his supraspinatus. So he had injections arranged and physiotherapy, as you would for rotator cuff tendinopathy. But then he developed swelling, and only then did he have an X-ray, which was suspicious for chondrosarcoma, and then that led to an MRI scan. And by this stage, the tumour had left the bone and was enveloping the soft tissues and now enveloping the neurovascular structures. And sadly, the only treatment for this was for him to have a 4-quarter amputation. So again, in this case, there were assumptions made. His age and his symptoms and his previous history all led to the clinicians involved to assume that it was a recurrence of his previous condition. He never had a repeat ultrasound, and sadly, he developed swelling too late to save his arm. And in this 63-year-old female who'd previously been treated for breast cancer with a lumpectomy and hormone therapy, but no chemoradiotherapy 5 years ago, developed hip pain, and as you might expect, she was managed with analgesia and physiotherapy by the GP. She was advised to lose weight and was given a walking stick, but never had an X-ray. And it's only when she was in a wheelchair that the X-rays identified that she had disease in the pelvis and in the proximal femur. And she had a CT scan, which showed that she'd lost both of the columns around the periacetabulum. And she had a navigated procedure to bypass the bone loss and to insert an ice cream cone prosthesis and to reconstruct her hip. That was the post-operative result. And 3 years down the line, she's very happy with her hip and now wants her other side done, although she doesn't have a significant amount of arthritis in it. But this case highlights the history. She had previously had malignancy and this was overlooked. And I think that anyone who's previously had cancer, particularly something that so commonly metastasizes to bones, such as breast disease or prostate cancer, even though they're in remission, we should always have at the back of our mind that they may have developed skeletal disease. What's interesting is that with her chemotherapy and hormone therapy and radiotherapy and bisphosphonates, actually the periacetabulum bone stock by 3 years and actually restored beautifully. So in summary, I would highlight the things that we see all too frequently, where the history that's presenting to clinicians is not in keeping with a typical injury mechanism. So normally somebody who breaks their femur and is under 50 years old, they've normally come off a motorbike or been in a high energy injury, not twisting in the kitchen or stepping down a curb. The history of pain prior to fracture should always be sought, and anybody with night pain, that is concerning for a bone tumour. Referred pain, so pain felt in one part of the body may be coming from somewhere else, and this should always be borne in mind. And please don't be led into assumptions about previous diagnoses or remission. Thank you very much.
Thank you very much, Jonathan. As I'm sure you'll agree, both of those presentations were extremely interesting. I hope you enjoyed them too. So I'm just going to share my screen and finish off the webinar, just to show you what we're trying to do to raise awareness. So can you see my screen? So as part of the awareness project and out of the results from our patient survey, we've developed a number of different resources to try and help healthcare professionals identify primary bone cancers. We know that they're very rare, and we're here to support you. So we have tweaked the flashcard that was developed by the medical students, and we have developed one for each healthcare professional. It covers clinical presentation and the investigations that you need to do, but it also has a main section around what you need to do if you suspect a bone cancer, where you need to refer and how you need to refer. We've also got a number of posters that we've been sending out. So we have a poster that looks at symptoms and misdiagnoses by anatomical site. We have an imaging poster, and we have a symptoms poster, really emphasising that symptoms do need to be taken in combination so that you can explore a full history. And these packs have been sent out to all hospitals with radiology departments in the UK. So we have sent 1,542 packs out. So hopefully your hospital and your department has these packs. But if you don't, please get in touch with us using the email address that we sent your invite out to, and we can send some of these materials out to you if you don't have them. So we would love for you to stay involved and really spread the word. So please do use our resources, be an ambassador and share them with your colleagues and your friends. Use them to host internal education workshops. Come to our annual conference. We've not had a patient conference this year due to COVID, but once they are up and running again, it would be lovely to have some of you there. We would be happy to come and present at any conferences or workshops to raise the profile. Please just ask us for any learning resources that you might need. And please do feedback. We want to support you and we want to provide you with the tools that you need. So just let us know how we can help you. And if you're feeling up to it, you may also participate in a challenge should you wish. So on that note, I just want to bring it back to our patients. So these are our daily inspiration and why we're doing this. So thank you very much for joining us this evening. I'll just stop sharing. So I think we've got time for a few questions, if there is any.
I'll just say, Zoe, that I think that everyone should have a very low threshold for referral, because Rajesh and I really don't mind. We have an MDT every single morning, and we get tons of referrals, but we're very quick at getting through them. And all patients who are inpatients and all children will have a phone call from the consultant immediately afterwards, just to let them know what the plan is, because there's normally a lot of anxiety about it, and often people just want somebody to double check the imaging and give them an opinion. And that's perfectly fine. And nowadays it's so quick to send imaging so swiftly. So I would just suggest that a very low threshold should be applied.
Excellent, thank you.
Just looking at the comments, so thank you, Rajesh, thank you, Jonathan, that really was fascinating. There are no, oh, here we go, first question. So why are GPs so hesitant to x-ray? Do you know why that may be?
I don't know. I don't think that it's seen as a first line investigation. I think in orthopedics and obviously in radiology, we have there's no impediment to doing x-rays for us. But if you work in primary care, maybe that's not so easy. You have a very short amount of time to be with the patient. I'm guarantee that primary bone tumours are not at the forefront of every GP's mind. But I think that where somebody returns, and this is what's come out in the campaign from BCRT, and particularly in the patient survey, that where people are going back and back and back, week after week, saying this is getting worse, there's no excuse not to get an X-ray.
I agree. So if somebody's symptoms are, if they've got the red flags of night pain, as Jonathan said, repeat attendances, I think at least an X-ray should be done.
Can I just ask, can Rajesh and Jonathan, do either of you have sight of the comments coming in?
Yeah.
There's a question that's coming from Connor Jordan, and I'm not sure I'll pronounce it right. So if you could read it aloud and then answer the question.
So GPs can definitely refer straight to us. That's because it's all done online. We do get GP referrals, and we certainly have 2-week waits. I think they tend to be for soft tissue sarcomas, I think because they're more common and they're probably encountered more by GPs. But also, bone tumours tend to be more occult. You don't often get swelling as you would do with a soft tissue sarcoma. So there's normally a more obvious physical sign which prompts a referral. There was a question about why do you get spiculated hair on end periosteal reaction rather than lamellar growth? It reflects the biology. So where the tumour cells are invading the soft tissue so rapidly, the bone formation is dragged along perpendicular to the direction of travel. But where the biology is such that the tumour is expanding, and then you're getting a layer of soft callus forming the line on the lamellar pattern on the X-ray. So it's just about the speed of the tumour progression into the soft tissues.
Yeah.
We don't seem to have any other questions that have come in. So I would suggest that we leave it there because we've come to time now. But to everybody who is online, if you have any questions that come to mind afterwards or anything that you think of tomorrow, by all means email us back to the email address where you were sent the invitation for tonight's webinar, and we'll be more than happy to try and get answers to your questions. And as just to echo what Zoe said earlier, if your radiology department has not received its pack, one has been sent to the hospital, but if you haven't received it for whatever reason, please do contact us and we'll be delighted to send you another one. Tonight's webinar has been recorded and we will be sending it out to everybody who registered tomorrow at some stage. And when that email comes out, it will have a link on to the webinar and a link on to our downloadable free information resources. But in addition, there is a link to a 7-question survey, which we'd really appreciate if you all answered, just to give us feedback on this webinar, how you found it, and it really will help us shape future webinars moving forward. And we just want to know how useful you have found it. So once again, thank you ever so much to Jonathan Stevenson and Rajesh Botchu for joining us.
Thank you very much, Jonathan and Rajesh.
We know that all your time is precious and it is an evening session. So thank you ever so much for taking the time out this Bone Cancer Awareness Week. And that's it.
Thank you.
Well, good night.
Thank
Good
you.
night.
Thank you.
Thanks.
Good night.